the follicles that would normally die. Now, when you come in with FSH in the patient, there is already a proportion of follicles that is in a phase of atresia. And most probably, we cannot rescue these follicles. And this might be one of the reasons why we need so many eggs, oocytes to retrieve in IVF, to have only a few oocytes that are capable of implanting and giving us a healthy baby. Next slide. Then what is very important is the age in the strategy that we have in our patients, because here, these are the results from our own clinic in Brussels. It's the Free University Brussels. It's a public hospital. We do like 5,000 ICSI cycles in the last 5 years, but we are doing ICSI almost, well, we started in 1992, so it's more than 20 years ago. And these are the data from all our cycles, and you can see that extrauterine pregnancy in the red line is not changing in relation to the age of the patient. But what is changing is the percentage of embryos that we replace in IVF that miscarry. So they are of a bad quality, these oocytes. These are aneuploid embryos, but we cannot see that because our selection today of the embryos is mostly done in the routine just by looking to the morphology. And the morphology is something subjective and not very precise to predict a miscarriage. And so you see that the overall pregnancy loss increases sharply from the age of 35. So this is, I think, for you general gynecologists in the room, a very important message I think that you can give to the patients. I think that our species normally should have children preferentially or at latest at the age of 35. Our best potential is probably between 20 and 30, and then we have a slow decrease, and we do not clearly understand today why we have this decrease. But it is the case that our gametes have a very high rate of aneuploidy, and especially this aneuploidy can be already in the oocyte, it can be in the sperm, but what we see also is that the embryo in the first few divisions, well, these divisions are not going with huge fidelity, and so this leads to abnormalities. Next slide. As I've said, in the general practice, you can do several things. The first point is classify the patients. You can do that by using endocrine parameters that we have mentioned, the classical ones, E2, progesterone, LH, FSH. To classify your patients in the 3 groups, the hypo-hypo, the PCOS-like patients, and the ovarian failure patients. And the strategy to treat the infertility in these 3 groups is obviously very different. And you see that most of the cases of the patients are WHO type 2. We have 10% of ovarian failure or low reserve, and these are very difficult patients to treat. And very rare are the hypo patients which have a hypothalamic pituitary problem, as explained by the previous speaker. And then, not rare is also the hyperprolactinemic patients. And then we have to check also the pituitary. Now, what can we do? I think we can consider a kind of a stratified approach. General OBGYN practices can contribute what I call to level 1, where you monitor the cycle of your patients in case she reports with anovulation and so on. So first the diagnosis, and then what you can do is to increase the chance of conception. If the men's semen is good, it can be timed intercourse, but then you have to know the LH peak, of course, and you can maybe supplement a bit the luteal phase. And the whole idea is to bring the sperm there at the moment that the woman ovulates. And we can do that in general practices when you have a rapid test, for example, for these hormones. And nowadays the technology is there and probably can also be available here in Indonesia for those who really want to specialize in this. A second level, what I call, is that you start to use stimulation in the patients, and we can just see quickly a couple of examples. So what you can do is combine maybe intrauterine insemination, but then you need to have a facility where you work up the sperm quality, or you can do timed intercourse if the patient has normal sperm. And then you have specialized ART clinics where I think this is, I call it level 3, because you will have, there the purpose is to do more heavy stimulation, which is more risky, and that needs to be done also with the lab, and so the investment is of a different kind. But as a general OBGYN person interested in infertility, I think you can contribute certainly very well to the first 2 levels. And when the patient, for example, after 3 or 6 months or 6 treatments is not pregnant, you might refer her to these specialized clinics. Next slide. So, of course, from the old publications from Wilcox in the New England, some of you might remind this publication, you see that the most fertile days are the days just before day 0, and day 0 is the LH peak. So we need to target that LH peak to be successful. Next slide. Next slide, yeah. So I think there exists a lot of guidelines for the diagnosis. You can read that in textbooks, and it has been explained by the previous lecturers here, so there are good strategies to do that. We have now ultrasound that has become of very good quality, also 3D ultrasound. I think we have a big luxury. You have a vaginal probe, you can go closer to the ovary and find a lot of things that can be done in outpatient clinic. However, there are not really good guidelines for the treatment follow-up during stimulation. So when should I measure LH? When should I measure estradiol? When do I need progesterone and so on? It's less easy to find like good recipes for that, and I think there is a need to develop some tools for the practice here. Next slide. I think we can go further. Next slide. So the ultimate goal is, of course, to obtain a singleton pregnancy, and it might be an illusion. I think the woman's body is made only for to carry 1 child. Occasionally there are 2, but it's a rarity in the normal population. So the challenge for infertility clinics consists in minimizing the risk of multiple pregnancy, minimizing the risk of ovarian hyperstimulation syndrome, and maintaining the greatest chance of pregnancy. So of course, if you can induce many eggs to maturity and you trigger them with HCG, there are 3 eggs, 3 times more chance to have a fertilization, but also more chance to have multiple pregnancy. And if you are too reluctant and too quiet in your stimulation, then you have no success, because maybe you will not even reach a dominant follicle. So there is a lot of difficulty in balancing this in the right way, and our experience in the hospital is that by doing frequent hormone analysis and having your ultrasound machine, you can come very close to an ideally stimulated cycle. Next slide. So how to improve ovarian stimulation? I think precise diagnosis. I think for the general practice, gentle stimulation, and then improve also the implantation. And of course, we have not talked much about the second part of the cycle, but when the egg implants as a blastocyst, sometimes the corpus luteum that must support the nidation in the endometrium is not good, and there also you have some therapeutics that can be used. Next slide. So just to go over a number of recipes. I think you made your diagnosis and you know that the patient has no severe hypothalamo-pituitary problem. So if normal pituitary function is there, in Belgium we say, and it's used very often in general practice, you can start with clomiphene citrate. It's an old drug, let's say, but it doesn't cost much. You start with a low dose, and you, in the beginning, in Belgium, the gynecologists did not monitor the patients because it's not so convenient. You have to take blood, send it. But today, if you can have these new tools that enable you to take the blood of a patient and have the results in 20 minutes, I think you can have a better view on how you treat the patient. And she will be pregnant much earlier. In general, although all the patients, when they are treated with clomiphene citrate, they do an endogenous peak of LH. So they will do their own LH peak. The only problem is that some patients do it on day 9, while others will do it only on day 15. And so we have to move away from fixed schemes, because otherwise we can be too early or too late. And this is also a reason why I think monitoring is important. Of course, we know that clomiphene unresponsive patients exist, especially those with hyperandrogenemic PCO, for example. And there we have to go and use gonadotrophins. And so there again, we have to start with very low doses, low dose step-up protocol, and so on. Next slide. This was the action of Clomid, you know that. Next slide. Okay, so what about analogs, GnRH agonists? And I think we use them exceptionally in a general practice of level 1 and 2. I think I would have used it only if with the low dose step-up protocol also I have an unmanageable patient, so she does an LH peak when the follicles are still too small. In that case, work from Glasgow and Edinburgh have shown years ago that when you associate the GnRH agonist, you make the patient like hypo patient, and she becomes pregnant more easily. And this is part due to the better quality of the follicle that you get, because if the follicle that you grow with your drugs is not completely well formed, and this happens more often than we think, you cannot expect her or it to make sufficient progesterone and to function long enough in the luteal phase. Again, if we use such type of drugs, it's obvious that we do monitoring with LH, estradiol, and progesterone. Next slide. I think we have to move on. Next slide. This is just an example of where we take blood. This is in a natural cycle, just monitoring a cycle, monitoring the patient's endogenous cycle. Next slide. If we give clomiphene citrate, these are the type of charts that we use. In the bottom, we have the values of the ultrasound that we measure, and here you have the different hormones, and here you have the medication. This was 5 days Clomid. And so this is a way to orient the treatment better in a visual way and have better success. Next slide. Next slide is an example of an HMG cycle and the frequency of measurement in the blood. There is something special that maybe you need to remember. When you start to treat a patient with HMG, you always need to give the ACG stimulus at the end, because quite a number of the patients, by the fact that you give HMG or FSH, they will not make a normal peak. And this is in contrast with clomiphene citrate. So with clomiphene citrate, you might skip that HCG injection, but never, I would say, with when you give HMG to the patients. Next slide. Okay, so is this, we jump just to the second point there. I think that Mild stimulation, these are the what we call improved ovarian stimulation. I think mild stimulation is very important because it has been shown also that you can avoid aneuploidies. There are studies in the Netherlands that show that. Is any gonadotrophin superior, recombinant or HbHMG? I think there is no superiority of one over the other. I think that both are valuable. I only know few exceptions while the one is superior over the other. But in general, for the general practice, there's no difference. Is there a need for LH bioactivity? Yes, I think, as I've explained you, LH plays a very important role in the final maturation of the oocyte. So we need to have it in our treatments. And one of the recent findings is that, in fact, because LH, when you inject it, has such a short half-life, it is cleared very rapidly out of the blood. In a couple of hours, it is disappeared, while ACG stays much longer and can have much longer effects. So I think for therapeutics, I think that ACG has some practical advantages, as has been shown also out of the results of very large studies. And then the pre-treatment agonist or antagonist, there I think the actual figures show that there is not any difference between the two, but I believe still that there are good indications to do long suppression in some patients. Next slide. What are the difficult cases that we have to work on? Those women that have become a bit older and so their reserve is smaller and they have a few large follicles, and then you see with ultrasound small, and then you are in a dilemma. Are you going for the large ones or for the small ones? Because if you try to get everything up, also the large ones will be too old, and over maturity is something that exists and that is linked to poor embryo quality. The PCO patients are still a problem today. I think some of us have experienced that whatever dose you give, you have always big surprises with them. And then the poor responders, that is very often linked with previous surgery on the ovary or deep endometriosis, and those that are born with a small reserve. Next slide. I think we can skip these slides, otherwise we will take too much time. Maybe we go to the conclusion slide. Can you go one slide after the other? Yes. More. More. More, please. Yeah, thank you. So here, this is, I think, a study from our team also that I wanted to show you. In fact, this assistant, which he's now a gynecologist, De Brugger, he checked in our group, he followed longitudinally the patients, and he looked to the patients that were over 37, and very often what we do there, he tested there those that received intrauterine insemination, and we compared them to patients that received ICSI. And as you can see, finally, with intrauterine inseminations also, you will become pregnant. Here is the pregnancy rate, here is the number of treatment cycles that you get. So you see that with intrauterine inseminations, when the sperm, of course, is not too bad for idiopathic infertility or for moderate male infertility, you see that you can obtain results of cumulative delivery rates of up to 20%. The only difference is that with ICSI you are much more quickly there. After 3 cycles you are there, while with your inseminations you will need a number of treatment cycles. So economically we have also to take that into account. Next slide. Finally, I think that the future of fertility management means also trying to do good research in the interest of advancement. I think long term, with some of these figures that I showed you today, I think also preventive strategies and education have to be given, especially in the Western society. we see that the young women that now start professional lives are not aware that there is an end point at their fertility, and we have to instruct it to them. And short term, I think there are many problems that still need to be tackled. Thank you very much.
Okay, thank you very much. Any question or comment? I think there is the afternoon so late. Okay, thank you very much for the Mr. Johan. And I surrender this speaker to the organizing committee.
Terima kasih kami ucapkan kepada moderator dan pembicara. Acara selanjutnya kita lanjutkan dengan acara plenary lecture kita pada sore hari ini dengan topik Fertility Preservation of Young Cancer Patient yang akan dipandu oleh moderator Dr. Binarwan Halim, SPOG Konsultan. Waktu dan tempat kami persilahkan.
Selamat sore rekan-rekan sekalian, terima kasih masih bertahan sampai sore hari. Cukup menarik tema sore hari ini, yaitu pembicaranya juga pakar, yaitu Profesor Nao Suzuki dari Saint Mariana University School of Medicine, Japan. So, Profesor Nao Suzuki ahli dalam bidang preservasi ovarium dan juga transplantasi ovarium. Dan pada sore hari ini, Profesor Nao Suzuki akan menyampaikan pengalamannya melakukan preservasi fertilitas pada pasien-pasien perempuan yang menderita kanker. So Professor Nao Suzuki is working in Saint Mariana University School of Medicine, Japan. Then he is expert in ovarian preservation and ovarian transplantation. So this afternoon he is going to give a presentation entitled The Fertility Preservation in Young Cancer Patient. Professor Nao Suzuki, time is yours, please.
Good afternoon, ladies and gentlemen. This is Nao Suzuki from Japan. First of all, I'd like to thank you, Anton, for giving me to have a wonderful chance to speak here today. And it is a great pleasure and honor for me to participate in this conference. Today I'm going to talk about recent topics on fertility preservation for young cancer patients. But I want to talk about as follows. First of all, I'm going to talk about development a new ovarian tissue cryopreservation method. In 2013, the American Society of Clinical Oncology, ASCO, updated the guidelines on fertility preservation for cancer patients. The updated panel concluded that no major substantive revisions to the 2006 ASCO recommendations were warranted, but clarifications were added. In the new guideline ASCO 2013, ovarian tissue cryopreservation and transplantation is considered experimental and should be performed only in centers with the necessary expertise under IRB-approved protocols that indicate follow-up for recurrent cancer. Today, they also show it for the patient equally, and in other words, freezing tissue from the ovaries, called ovarian tissue cryopreservation, is still investigational procedure. This slide shows various options of the fertility preservation in the FERT project in 2011. For women who require immediate cancer treatment or those who are not good candidates for ovarian stimulation, ovarian tissue cryopreservation may be an option. The technology of ovarian tissue cryopreservation can protect a large number of oocytes and transplantation of cryopreserved ovarian tissue also has a hormone replacement effect because the transplanted ovarian tissue secretes estrogen. In addition to fertility preservation, this technique has the potential to improve estrogen deficiency symptoms, prevent cardiovascular damage associated with low estrogen levels, and mitigate loss of bone density. Because it can perform it in a short time, it is possible when there is not enough time until start of cancer therapy, as I told you. So even for an unmarried and young girl, this technology can be indicated. Professor Donay has reported the first case of a live birth after orthotopic transplantation of cryopreserved ovarian tissue in Lancet 2004, as you know. After 6 years of the initial anti-cancer therapy, sold ovarian tissue were implanted to the peritoneal window, very close to the ovarian vessels and fibria on the right side. 5 months after reimplantation of ovarian tissue, recovery of regular ovulatory cycle was confirmed. Laparoscopy at 5 months confirmed the ultrasonographic data and showed that presence of a follicle at the site of reimplantation, clearly situated outside ovaries, both of which appeared atrophic, like this. So from 5 to 9 months, the patient has menstrual bleeding and development of follicle. 11 months after the implantation, intrauterine pregnancy was confirmed, and finally live birth was achieved. According to Professor Dorman's report entitled A Review of 15 Years of Ovarian Tissue Bank Activities, 1,473 patients in total were performed ovarian tissue cryopreservation right now. The main two indications are hematological malignancies and breast cancer. There are also particular issues relating to very young girls, for example, acute leukemia, Turner syndrome, benign hematological diseases, sarcoma, and CNS cancer. And 170 young girls with such disease were performed ovarian tissue cryopreservation in Europe. This is the largest and most comprehensive study to describe and analyze indications and clinical patient characteristics before and after ovarian tissue cryopreservation. Professor Dormans described that this procedure is safe, easy, and promising. This slide shows a photo taken at the University of Copenhagen when Professor Andersen lectured to us on his work, together with data shown during the lecture. In Denmark, ovarian tissue from 572 patients were cryopreserved between 1999 and 2014, and tissues were transplanted into 49 patients between 1999 and 2013. As reported by Professor Dormans in JRG, 80% or less of women having ovarian tissue cryopreserved have breast cancer or blood diseases. And about 80% of such patients in Japan have breast cancer. Professor Andersen reported that 40 live births were achieved through ovarian tissue cryopreservation and transplantation as of 2014. No abnormalities were seen during pregnancy, and babies were born normally. Orthotopic transplantation was done more often than ectopic transplantation. A slow freezing method was used in all but one case. Ovarian tissue has been transplanted into about 150 women worldwide. As I will explain later, the second baby whose mother underwent ovarian tissue cryopreservation by vitrification was born last year, meaning that 41 babies have now been born to mothers following such technologies. So as you know, the standard method of ovarian tissue cryopreservation is slow freezing at present. But vitrification, on the other hand, in recent years, there have been various reports on the superiority of the vitrification method. Professor Hobata reported that the tissue showed significantly better preservation with vitrification based on observation by electron microscopy after freezing human ovarian tissue compared with slow freezing. This slide shows the pros and cons of vitrification stated by Professor Hobata in World Congress on Fertility Preservation 2009. According to her statement, process of vitrification are excellent survival of ovarian stroma and blood vessels, a fast method, no particular apparatus needed, also feasible clinically. Excellent survival in tissue culture. On the other hand, cause of vitrification are no live births reported so far at that time, and it requires good training. Concentrations and osmolarities and the speed of the procedure are of extremely high importance. A toxic influence on the tissue is possible if less trained personnel. Therefore, we planned the preclinical study for establishing ovarian tissue vitrification method since 2006. The present study was performed on cynomolgus monkeys with the objective of determining the optimum site for heterotopic transplantation of ovarian tissue and optimum method of cryopreservation to enhance the clinical application of this method. First of all, we performed transplantation using the fresh ovarian tissue of 2 monkeys to determine the optimum site for heterotopic transplantation. As a result, 1 developed follicles was found by abdominal ultrasound in the retroperitoneal iliac fossa at the site separate from the uterus. Developed follicles were confirmed macroscopically in the left retroperitoneal iliac fossa region at laparotomy, like in slide. And also, aggregates of developed follicles were found in the omentum. Finally, matured oocyte was successfully collected from the both heterotopic transplanted sites. After microfile transition of the harvested ova, 5 embryos were obtained. Finally, we established an appropriate method of heterotopic transplantation using fresh ovarian tissue in monkeys. So therefore, we started to develop the ovarian tissue vitrification method. At first, we investigated the effect of vitrification solutions and equilibration time on the morphology of vitrified preantral follicles in cynomolgus monkey to decide the optimal condition of ovarian tissue vitrification. We compared 2 types of vitrification solutions, such as VS-EGP solution, which includes ethylene glycol, and VS-ED, which includes DMSO solution, as you can see in the slide. In addition, we examined it in 5 minutes and 10 minutes and 20 minutes